I'm going to talk today about something that I think is really probably one of the things that many of you are familiar with on the periphery, but this is something that I think is a newer technology in the last few years and could potentially be something that might benefit you or someone you love. So a little bit about me. I, again, live in Napa, California. I'm from the East Coast originally. I am a physiatrist by trade, and then I did a fellowship in pain management. I have ridden horses most of my adult life. In fact, I jokingly say that my parents tried to kill me from the age of 4 because they put me on horses and on skis. And I have actually had surgery on every limb now. So at this point, I'm fairly lucky that I've survived. But after going through the amount of injuries that I've had, I've definitely understood how the recovery phase of injury and surgery has affected my life and my patient's life as well. And so it seemed like a natural segue to go from physiatry to interventional pain management. I am deeply committed to helping my patients improve their quality of life. I think without quality of life, it's really hard to enjoy why we're here, right? I do want to have alert people that I am a consultant for a number of companies, including Abbott, Virtus, Medtronic, Omnia Medical, Boston Scientific, Pain Tech, Saluda. I do that because I like to teach my colleagues as well as mentor my colleagues in some of these implantable devices. So if you have any questions, this is my email address. I just want to share some statistics. It feels like I'm teaching people who are probably much more well-versed than I am in a number of these things. But the reality is data from the last few years shows that over 100 million Americans are affected by chronic pain. And this can affect all parts of our life: sleep, activity, depression, anxiety, relationships with our loved ones. And when we think about neuropathic pain, or specifically complex regional pain syndrome, it is one of the most prevalent yet undertreated chronic pain conditions facing patients. And I'll talk a little bit about why that is. But we think that there's probably well over 635 billion people, $1 billion annually spent directly and indirectly managing care around patients with chronic pain. So why do so many patients who have chronic pain go undertreated? And the answer is because a lot of these things are not independent factors, right? Again, the interrelation of chronic pain with the way we feel about our life and the way we sleep. So when we go and see our providers, physicians, advanced practice providers, it might be hard for them to isolate what's the real issue going on. And then patients don't actually have an opportunity to get directed to the right place. So if you're dealing with a primary care physician or advanced practitioner who's not aware that there might be someone who is an interventional pain physician in your area who can perform these advanced techniques, you might not get access to that care, right? So it's important that you become knowledgeable about it so that you can advocate for yourself. And, not knowing about these therapies can also lead to inadequate pain control, because even if you are seeing an interventional pain physician who might not be versed in some of the more advanced techniques and interventions, you also might not be able to get those procedures, even though you're seeing a physician, because there is variability from training program to training program. And then again, particularly in the last 5 to 10 years, with the increase with regard to concerns around opiates, there's a reluctance for people to prescribe medications because of the fear of addiction or habituation. So pain management physicians in general, this is again a generalization because training does vary. We have a number of options, including medications, injections, implantable devices, integrative therapies, and sometimes, because things are constantly changing, clinical research trials. Now, it's really important to also understand that, again, these things are changing. And in the last 10 years, the devices that are on the market and the therapies that are on the market and the medications that are on the market have changed dramatically just while I was in training till the last 10 years that I've been in practice. So, staying abreast of this can be very difficult. The problem that I think a lot of people want to know the answer is what treatment's right for me, but there's really no formulaic way to treat a patient. Everybody is unique and everybody responds to medication differently. If we think about ice cream, not everybody likes vanilla ice cream and not everybody likes chocolate ice cream. So uniquely, our bodies respond to a medication in one way or a device in one way. And even the therapy that I'm about to speak about, which is neuromodulation, not everybody's going to respond to that therapy as well. So finding the therapy with your providers that is unique to you, that is going to work for you. And it's not going to be one singular therapy. It's more than likely going to be a number of things together. So, as I'm sure you all know, causalgia is one of the older names that we've used to call CRPS. But there are a lot of quotes about this over the years because of what we've seen and the way it's been addressed in the literature. But one of the most terrible of all tortures, which a nerve wound may affect, and the reason that's something that I think we can relate to is because I myself sometimes wake up in the middle of the night and I have like a numbness or a tingling on my foot. And I think, oh my goodness, if I have to live the rest of my life like this, I'm most likely going to cut my leg off. But I know that that's A, not a realistic option. And B, it's not something that I have to live with permanently, but that's not something that other people don't suffer from. Now, dorsal root ganglion technology is a newer technology that's been released in the last few years and is FDA proven. This is specifically for foot pain, ankle pain, knee pain, hip pain, groin pain, and pelvic pain. I'll speak a little bit more about this, but this is only indicated for pain from like the mid body down in the United States because of FDA approvals. The dorsal root ganglion is kind of like a gatekeeper. So what it does is it's where the peripheral nerve um, volumes and things that's going on outside of the spinal cord are then transmitted through the spinal cord. And because we know that there's a problem of a functioning nerve in the periphery that is actually causing these bad signals to be sent to the brain saying, I hurt, there's a problem. The dorsal root ganglion, what we found from studies, from data, from transecting it in animals, is that what we know is that this is where a bunch of the cell bodies that are damaged live. Now, this is something that I think people can think about because most of us are familiar with shingles. And when people get post-herpetic neuralgia, the reason that that can become a progressive issue is because the virus, the shingles virus, actually lives in this dorsal root ganglion. And so what happens is, similar to a lot of patients with CRPS, they can get a flare of that and they get that persistent nerve pain in the dermatomal distribution that they had their shingles virus. Again, multiple names: causalgia, Sudex atrophy, shoulder hand syndrome, migratory osteolysis, mimocausalgia, algodystrophy, reflex sympathetic dystrophy. And I think the problem is too, in training, we see these pictures and we assume that patients who have complex regional pain syndrome, whether it's type 1 or type 2, are going to come in with these very obvious signs. And I believe firmly that the underdiagnosis of CRPS is linked solely to these kind of things. And instead of really accurately diagnosing patients who don't necessarily have the significant changes that we see in these pictures, even patients that have mild changes but persistent pain or burning feelings or the tingling and the kind of sense that it feels swollen, even though it may not be swollen, can still be patients who do meet the criteria, both of Budapest criteria and the IASP criteria for complex regional pain syndrome. Again, changing the name may make the diagnosis feel better, but it doesn't increase our knowledge of the mechanism of pathology. And even though we know that the dorsal root ganglion is involved in this, we still don't understand 100%. Again, this is a patient here that you can see had an ankle sprain and developed severe CRPS now. But the average person who comes in, whether it's after a knee surgery or a hand surgery or even a hernia repair, may not exhibit this degree of signs and symptoms. So it's really important that you are able to express what you're feeling, that it feels weak, or I can't move because of the pain and things like that. And it doesn't always need to follow a specific injury or a trauma or a surgical procedure. Again, I know that complex regional pain syndrome can affect both upper and lower extremities as well as other parts of the body. For the purpose of this discussion, please note that I'm sticking to lower extremities because the indication for dorsal root ganglion stimulation in the United States is only for lower extremity, groin, mid-body, and below. Traditional neurostimulation is a therapy that uses like low amplitude electricities to basically send a signal to override the painful signal that the brain is using to say that it's hurting. I actually heard someone in the intro say that they were a cyborg. I'm assuming that they have one of these devices implanted. Again, the goal is to intercept the pain signal before they reach the brain. If you are concerned about a device being implanted in you, or when my patients express concern, I think about a person who might need a pacemaker. This is essentially a pacemaker for your nerves. If you went to the hospital and you had a cardiac issue and you needed a pacemaker, you would probably not hesitate to have a pacemaker placed. This has been going on for well over 40 years. We've used this therapy to help many people. The technology, again, has changed dramatically in the last 40 years. Even in the last 10 years, almost all of the devices are fully MRI compatible or some degree of MRI conditional. So traditional neurostimulation typically consists of three components: a generator or a battery. This is the small device that basically powers the device. A wire, that's an insulated wire that has some electrodes on it. And this is placed in the spinal canal or the epidural space. And then a remote control that allows you to adjust it. Now, depending on the device brand that you get, you may need to make frequent adjustments or charge it. Some of them you don't really need to do at all. Everybody is going to have access to a therapy, which is merely something that is, again, at the disposal of your patient and physician relationship. This is a case I implanted in a woman, and this is an issue when we talk about limitations of traditional spinal cord stimulation. So because we're dealing with an area that there happens to be fluid around the spinal cord, there can be some variability as you change position. There can also be some issues with the lead migrating slowly a little bit, depending on if it wasn't anchored or if you had a fall or some kind of injury. This is also a lot more broad. So if you have a very specific injury area and your CRPS fortunately has not spread, let's say it's just like a toe, this is going to cover more than just your toe. It's going to cover a larger part of your body because, again, we're not targeting a specific nerve. We're using this to target over the spinal cord. And there is, because of the use of this over an area where there is some spinal fluid, a loss of energy that happens as it's kind of transmitted through this area. Now, when we think about this is kind of an image that's going to just show, I'm sorry you're going to hear me talking over this, but so as you can see, that's courtesy of Abbott there. And so the CSF flowing around, but then when we look, this is again, as patients change their position, you're going to see that there is some degree of movement of the wire because of the way it is. So now when we look at the dorsal root ganglion, which is off to the side here, you can see there's very limited CSF or spinal fluid around it, which means that we're not really relegated to worrying about how the patient moves to worry about how things are going to affect stimulation. So when we think about dorsal root ganglion stimulation, again, these are located outside of the spinal cord in an area where there's not any as much spinal fluid. And this is a much newer technology, again, specifically indicated for mid-body to the ground. And it is a form of neurostimulation where we can target much more focal areas. It's unique in that it's for targeted areas. So when you have, like I said, a small area of pain that is we're trying to target, like your foot or your ankle, when we use traditional stimulation, you can see it's a little bit harder to get the, just that focal area covered. But with DRG, we know based on the anatomy that we can put the lead in a specific area and essentially cover just the area that we want to target. When I think about patients, I'm looking for patients with both CRPS type 1 and CRPS type 2. I think what's amazing about this therapy is up until recently, we haven't had a lot of therapies for patients with chronic groin and pelvic floor pain, particularly if they've had multiple surgeries to the pelvic floor. And again, making sure that people understand that there are some limitations to this therapy, but still it's an excellent thing to use for focal issues, particularly of the lower body and lower extremities. So these are some pictures of some wires placed. It is placed via epidural access. So using a small needle, we're able to place a little wire into the area. And then the lead is placed out through the hole or the foramen. And what you're looking at are these kind of little 4 dots that you can see. I don't know if you can see my my mouse pointing at them, but those 4 dots are the electrode, and then we create this kind of strain relief loop to keep it in place. Again, in the United States, this is only FDA approved for treatment of the T10 through S2 levels. So that means kind of, again, from the mid-body. The dermatome for T10 is pretty much the belly button. So basically for pain from the belly button down. Although off-label, it has been used, and since this isn't a CME course, I can tell you off-label, it has been used for higher levels in the United States for post-thoracotomy pain. And although it is not commonly used for upper extremity pain here in the US, there are uses of that in other countries like Australia. Spinal cord stimulation on the left, what we're looking at are, again, for patients with back surgeries or chronic low back and lower extremity pain and complex regional pain syndrome, but DRG therapy can be used more for specific areas. So if you have persistent pain after a total knee replacement, or again, an amputation or other injuries, this might be a therapy you might want to consider. Some of the contraindications that might prevent you from being a candidate for this therapy include if you've had previous surgery at that level. For example, if you've had a surgery at L5 and we're trying to target your foot or your ankle, and since we would like to maybe go in at L5, it might be something that precludes us from going in that area. Stenosis is narrowing. So because we have to go out that foramen, if the foramen or the hole where the nerve root passes out is a little narrow, it would preclude the physician from being able to place the lead there. Another issue might be someone's inability to operate the device. Thankfully, the device does not require a lot of input, but it does require some feedback from the patient to be able to report where they're feeling sensation when we turn it on. But ideally, the goal is for you not to have to really do a lot of interaction with this device. And the other option that might consider this person not a great candidate for therapy, and really is someone who might fail the trial. Again, while a significant amount of people would be an excellent candidate for spinal cord stimulation, regardless if it's traditional spinal cord stimulation or dorsal root ganglion stimulation, the most important thing is having a trial to see if you're a candidate. Now, one of the requirements from insurance, regardless if it's private insurance or Medicare, is that you must have a psychological evaluation. Now, the reason that the psychological evaluation is in place is not because any one of your providers who you're going to interact with thinks that you might have some kind of emotional issue. In fact, I truly believe that if you're suffering with chronic pain, you're bound to have some degree of depression or anxiety around that because it affects so much of your daily life. But what they want to make sure is that you understand there's a trial process and what the trial process comprises of, and B, that there's not some untreated psychological or psychiatric issue that needs to be addressed before you could potentially move forward with this therapy, and C, that you understand the risks and benefits of the trial. Now, a lot of those things can be dealt with directly with your provider, but still, this is a requirement of all the major insurances and Medicare and Medicaid and Medi-Cal as well. So please don't be put off when you hear that that's something. Now, why can we do something like dorsal root ganglion stimulation? Well, we know that the nervous system is organized in what we call dermatomes or maps. And because we know the nerves go to certain areas, we're able to place the wire around the nerve area that is consistent with those dermatomes. So as you can see on the image on the right, the dermatome at T10 is about the belly button. Now, I'm not as thin as this drawing, so my T10 hangs a little bit lower, but these are used as general guides. And as we know in CRPS, it's not necessarily a specific dermatomal distribution, because as CRPS spreads, it can spread into almost like a stocking or a pantyhose, and it can go from one side to the other. But what we do know is with regard to dorsal root ganglion stimulation, that if we treat the original site of injury or the beginning of CRPS, then we will have a much better outcome. So if you have, let's say, an entire leg that is affected and afflicted, but your original injury or the original start of your pain was like your big toe, we would start with the treatment targeting the nerve of the big toe, because that's the original nerve that started the offending injury and the affliction. Again, will this work for me? This is a question that I think everyone wants to know the answer to. And I think regardless of a treatment, when I offer them to one of my patients, whether it's an injection or a medication, I don't mean to be like flippant when I say if I could predict the future, I would have bought a lottery ticket and I would be laying on a vacation island somewhere. But the reality is that the only way to know is that you have an opportunity to test this out. I understand the fear of testing something out because realistically, many patients who are suffering from CRPS have at some point had a surgery that affected them and has given them this worsening pain. And one of the things that we do know is that any procedure, whether it's minimally invasive or not, you run the risk of bleeding, infection, worsening the pain, and production of new pain. And although I don't quote Dr. Oz a lot, one of my favorite quotes is that he said, a minimally invasive procedure is one done on someone else. So it's really easy for me to recommend this, but I also understand, how scary it can be to potentially go through another procedure if the procedure is what actually caused your issue, and B, to, be nervous about having something implanted in you. Um, but unlike any other surgery in your life, this is something that you get to test out for a week. So for the first week, basically what will happen is there is a needle that's placed under an x-ray while you've got some sedation, and the wire is placed in place, and then everything is taped to your back with an external generator. So for that first week, you actually don't have any incisions. Nothing is actually implanted in you permanently. And during that week, you get to test it out. Now, there's no other surgery in your life that you're going to get to test out. Like if you decide that you need to have your gallbladder taken out or your appendix taken out, and then one day you change your mind about it, no one's going to put your gallbladder or your appendix back. But at the end of the week of this trial, no matter what, if you like it, it comes out. If you hate it, it comes out. You do not need to go back to the OR or the procedure room to take it out. You will just be able to take it out in the office, and then you are the one to make the decision. So your physician doesn't make the decision, I don't make the decision, but assuming that you've had 60% reduction in your pain or more, then you are someone who would be a viable candidate to move forward with the permanent implant. Now, why do I say 60%? I think realistically, the way that anybody is successful with any type of intervention, whether it's medication or an injection or therapy, whether it's cognitive behavioral therapy or any other thing, including vitamins and supplements, the reality is that there's not one thing, particularly for CRPS, that is a panacea or is going to cure everything. So we talk about a reduction in someone's pain that's going to help them have a better quality of life. And for me, that is the goal that I am asking my patients to consider. So their pain might not be 100% relief, but if they are 60% better and they have that significant reduction of their pain, do they feel like they could have a better quality of life based on that? Again, not everyone responds the same way. Some of the complications can include painful stimulation, loss of pain relief, and certain surgical risks. When we're dealing with placement of anything near nerves, there's obviously a risk. But again, this is why we take into account the precautions of making sure that you haven't had previous surgery at that area. We evaluate the images to make sure that you're an appropriate candidate. But I think that now that it's been out for quite some time, we have enough studies to show that this can be extremely helpful with regard to patients' overall functional quality of life. And I'm really happy to see that with regards specifically to studies in pain management, that when we are considering is a therapy beneficial, it's not enough to just ask people like, did your pain score go down? Because let's be honest, the majority of us don't really understand the pain score, right? And it's really easy for someone to ask you like, what's your pain level? And you're like, oh, I'm an 8, but you're sitting there comfortably and that person is going, well, you can't be an 8, but for you, an 8 is where you live. So I think trying to ascertain like what is that pain scale really mean and how do we make it something that we can extrapolate from patient to patient has been difficult. And so we've started using other quality of life markers. So the target study was performed at over 45 centers across the United States, and there were 426 subjects enrolled. So we did enroll a number of people, But at 12 months, have seen, based on various quality of life, and I didn't put all the data in here because I didn't want to bore you guys with statistics, but we did see that patients self-reported 60 to 70% improvement in their functional levels, in their social participation, a dramatic decrease in their representation of anxiety and depression. And these are all self-reported on very reputable and reliable indices that we use, like the Oswestry Disability Index and others. And the majority of patients, I want to say 70 to 80%, still reported at 1 year a high rate of satisfaction with the device. So what we know, I mean, you guys, again, living with this, you know that this is something that in a short time, it can convert the brightest spirit into a haunted, driven upon himself, thinking only of its disease, selfishly indifferent to everything and everybody, and constantly obsessed by the dread of recurrent spasms of pain. Complex regional pain syndrome is something that, like pain in general, is an N of one, meaning that you are the individual that is suffering with this. And no one, not even your physician, can really begin to understand the degree that it affects your life. But I hope that my colleagues do, and I am hopeful that you'll hear this panel in the next hour of physician colleagues who can tell you about their experience and how they manage it. Because to me, I assume that everybody's fight is individual and different, and the things that affect them and stress them out are going to be different than someone else's. But I want you to know that there are therapies out there. These are a bunch of pictures from a number of cases over the years. The one on the left for a guy who had a traditional dorsal column stimulator, but then he continued to have persistent groin pain or testicular pain. And so we removed his system and placed this other one. Another patient with CRPS in the groin and abdomen. All of these patients have gone on to have way better quality of life. And I only can hope that I was able to give you guys a small amount of information about something that I'm very passionate about. And I am super happy to help anyone who has questions. You can find me on Instagram at Dr. Weisbein. I know that Roxanne has done a great job of tagging me in all the posts, and I'm sorry I still owe you a booklet, Roxanne, but I'm so thankful to be a part of this. I'm sorry that we couldn't do it in person this year, but I appreciate the opportunity to share a therapy with you all that I'm extremely passionate about. And I hope that in the future, if you have questions, you can reach out to myself or one of my colleagues. You can find a provider at Abbott's website about neuromodulation. They have their traditional dorsal column stimulation, which is Proclaim XR. But you can Google DRG Stimulation and Abbott's website will come up. And currently they are the only company in the United States that is able to offer this therapy. Thank you so much for your time, and I really appreciate it. Again, if you have any questions, please feel free to contact me.